Everyone, and happy holiday season. Welcome to the 41st of our Town Hall series today. As always, I'd like to thank the members of our Society for Leading Medicine for their great support, and particularly our chairs, Waverly and Adam Peaks, as well as Kristen and John Berger for their hard work. Now, if you haven't had a chance to meet our wonderful quartet and those individuals, we actually are having an event next week, Tuesday evening at the Ion. If you're a member of the Society, you should have received an invitation to that for that reception. It's the Rice Ion up in Midtown, and it should be a fun evening and a very interesting event. Today we've got a great topic. We're going to be talking about facial reconstructive surgery and really a breadth of features of that and things that are possible within the field. We have two great leaders from the institution here, Dr. Jamie Gattino, who is the chair of the Department of Oral and Maxillofacial Surgery for Houston Methodist, and Dr. Anthony Brissett, who's the vice chair of that department, of the department and division chief of facial plastic and reconstructive surgery. As always, we'd love to get your questions. We've gotten some in advance, and I know there'll be some coming in. You can either text those to the word DeBakey, D-E-B-A-K-E-Y, of course, after Dr. DeBakey, text 37607, or you can do it there, right there in the chat. And to be able to answer some of your very specific questions, we have two great people in the chat area as well. We have Dr. Najee Damian, who's the vice chair of oral maxillofacial surgery, and we have Dr. David Renhefo, who is a fellow in otolaryngology and head and neck surgery here with us as well. So thank you both, and I'm going to turn to Dr. Gattino and ask Dr. Gattino to talk to us a little bit about artificial intelligence.
Oh, good morning. Thank you again for the kind introduction and the opportunity to share my work with you. So I'm going to talk to you about how artificial intelligence benefits facial reconstructive surgery. This is a young lady. She's 16 years old, and she developed a fairly severe jaw deformity because she had juvenile arthritis as a child. And she came to Houston Methodist, and we performed an operation, and this is the final result of her surgery. Now, this kind of reconstructive surgery requires extensive planning before the operation. And this planning is usually done in specialized software that takes a CAT scan, and from the CAT scan we make three-dimensional models of the face in which we can practice the operation. And we have an atomic aligner, a software that we developed at Methodist that is now FDA approved, and we use it daily in clinical practice. This is another patient, is a young lady that has hemifacial microsomia, is a condition that is congenital, and in this condition, all the tissues on one side of the face are underdeveloped. So she was referred to us for a reconstructive surgery. And the first step is to create a three-dimensional model of the face in which we can plan her surgery. Now, building these models is difficult. We usually start from a CAT scan, and in the old times, we used to do something called threshold segmentation, which you can select certain parts of the CAT scan based on the grayscale, and from them, make a three-dimensional models of the face. So such a model is very poor. They have holes where bone should be. There are areas that are selected that are not really bone, and there has a lot of artifacts for the metal. And it takes one of our engineers 8 hours to clean this model so we can use it for reconstruction. So doing this for every single patient was just not practical. So to solve this problem, we developed Skull Engine. Skull Engine is a deep learning network that takes a CAT scan and separates it into the different components of the face. Not only it will make all the three-dimensional models that you will see in a minute, but it also finds about over 150 key landmarks we use for the reconstruction. So this is Skull Engine running in the background, and something they used to take now in the past 8 hours, now we can do in 3 or 4 minutes completely automatically. And as you can see on the left, the artificial intelligence engine will select in green all the structures of the midface, on yellow the mandible, all the teeth and the soft tissues. And our software, an atomic aligner, will take this information, and this is real time. This is how long it actually takes to build a three-dimensional model. In this case, will be a three-dimensional model of the lower jaw. And here you have it. So using this routine, in a few minutes, a clinician can make a separate model of the midface, a mandible, the upper teeth and lower teeth as separate objects, and the skin. So this has facilitated facial reconstruction tremendously. Another important task for us is to put accurate models of the teeth into these virtual models. And doing this automatically is also requires landmarks. So we have built a separate deep learning model called Dental Point Net that automatically finds all the landmarks of the teeth, something that by hand used to take us about half an hour of work. And this is also a use as the first part of planning is to set the bite into the ideal alignment. Our software is the only software can do this completely automatically in about a minute and 28 seconds. So going back to this young lady with hemifacial microsomia, again, this is her deformity, and we're planning the reconstruction. And this is her model, and we go into the computer, and this is what we're going to plan to do for her. We're going to take the upper jaw and reposition, and we're going to cut the lower jaw in 4 different segments that we're going to move into a new alignment. So an important question is that, yes, you plan this in the computer, but how are you going to execute this in the operating room? How do we go from the left to the right? And within Anatomic Aligner, we have the ability to fabricate templates and guides that we use at surgery to set all the pieces in the right alignment. We can measure the size of gaps that we're going to put bone grafts in. We can map all the areas of collision that we have to resect bone to allow for the movement to occur. But more importantly, these days, we have the ability to 3D print in titanium. This is a template that will be placed on the jaw of the patient, and we are going to make the cuts very precisely through the template, and we're going to drill all the holes for the fixation screws. The hardware, the fixation hardware, is made specifically for each patient, patient-specific, and is 3D printed in titanium and sterilized before the operation. So when we go to surgery, we put the templates, we drill all the holes, we make the cuts, and use these custom plates to be able to execute this plan. As you can see here, to the left is what we plan to do, and to the right, we were able to get exactly what we have planned because of this pretty amazing technology. So this is the kind of outcomes we can get in a single operation from before and after because of this technology, and artificial intelligence is just facilitating the whole process. Now, the current paradigm, what I just showed you, is we'll call bone-driven planning, which is the current standard all over the world. So surgeons have one of 2 approaches. One is says, okay, you have a skeletal deformity, and I'm going to make your bones normal, and the expectation is by making your bones normal, your face is going to look normal. Or the surgeons, they say, no, yes, you have a skeletal deformity, we're going to normalize the skeleton, but I want to be sure that your soft tissue looks good, that your face looks good, so develop software to predict the soft tissue changes of the face, and then you assess that and you adjust the bone plan accordingly, and you iterate several times until you get exactly the final outcome. So we also develop a program that can morph the soft tissues of the face when we move the bones to predict how the face is going to look. And this is such a program. You see, as you move the bones, we can predict how the face is going to look. The problem with this approach is it takes us about 2 days of actual work and computing to be able to make the simulation. So you can do it for individual patients, but it's not practical for everyday use. So the new paradigm that we're developing now, and I think the only people in the world doing this, we have the idea of what we'll call a soft tissue-driven planning. So here you have a skeletal deformity, and can we predict the optimal facial appearance for that patient? How do we want the patient to look at the end of the surgery? And based on that, then calculate what is the proper skeleton that goes underneath the facial appearance, and use that predicted skeleton as a guide for repositioning of the bone segments. So we have such an example here of a patient who has a asymmetry of the lower jaw where it grew asymmetrically and the face is asymmetric. And we have on the left the patient's condition, and this is how the new network is predicting the optimal facial appearance for that patient. It makes it symmetrical, and we don't want them to look average. We want them to look like their relatives, which is and also a new paradigm. And what you see here, that in order to make this patient look normal, the soft tissues here have to project sideways a little bit more. And so we have this predicted outward appearance, and an artificial intelligence network can predict how the bone underneath need to be in order to support that facial appearance. And then we have this now calculated optimal skeleton. And for example, in color you see in orange and blue what was the original surgical plan, and in light green you see the predicted template. And if we didn't have this template, we would have failed, because you see they're not perfectly matching. So here we have the opportunity to revise the bone plan to make this match the template to perfection, so we achieve that ideal facial appearance. So if we extend this to other areas for trauma and tumor reconstruction, this is a fellow who was in a terrible motorcycle accident and fractured all the bones on the face, went to a small community hospital where the surgeon put a lot of fixation hardware, but failed to put the bones in the correct alignment, and the patient comes to us. We have no basis of where should all these things go. You know, I can cut them and move them, but I don't know. The only thing we have is a photograph that the family gives to us, and this is a regular, two-dimensional photograph. So we took this idea from this patient and said, okay, we have this two-dimensional photograph on the left, and we can select key landmarks, and we can create a three-dimensional model of the face just on landmarks. And there is an open source database called the basal face model that has the surface of the skin with the landmarks, and we can adapt this model to the patient's key landmarks to calculate the three-dimensional surface of the skin for this particular patient. And then in the next stage, now we have the two-dimensional face that we turn into a three-dimensional face. And we took hundreds of examples of normal patients who had CAT scans here in Methodist for other reasons, for example, sinus disease. And we learned two things from this database. We learned what is the relationship between the bones and the soft tissues of the face, the outer appearance, and we learned what normal bone is like. So now we can take this outer surface appearance of the face, and we can initially calculate what is the skeleton that should go underneath, and we have to adapt it to the patient to personalize it. But if we do a full adaptation, it's going to be abnormal. So this shape model is going to constrain this adaptation, so it will always be normal. It's adapted to the patient, but it will always be normal. So this is a pretty nice synthetic experiment we did, where we took a skull of a patient and we created this defects. For example, in this example, you're missing all this part. Here you're missing the whole left side of the face. Here you're missing the lower jaw. Big examples. And we asked the artificial intelligence engine to predict what goes there. And you see in the second row, even though all this is missing, we were able to predict exactly what goes there. So a patient can come to us now missing a whole part of the face, and we can predict what goes there and use it for the reconstruction. So that's an incredibly powerful tool. So what we have done so far, we already have an artificial intelligence pipeline to do segmentation. We can find the landmarks. We join them together. We can find the landmarks of the teeth. There's something we didn't talk about it, but we have the ability to create three-dimensional bone models of the face based on an MRI to save radiation. We're done clinical validation of all these things. So the next step where we're seeking funding is something called federated learning. So the problem with artificial intelligence, in order to get great solutions, we need to have very large databases. And at Methodist, we have a limited amount of examples, and other hospitals have examples, and other hospital has examples, but we cannot share our databases because of patient confidentiality. And even if you anonymize all the CAT scans, the face itself is confidential personal information that we cannot share. So we came up with this idea. It's called federated learning. To apply it to this, we did not develop federated learning, but we developed with our collaborators what we call federated cross-learning, where we develop an artificial intelligence model that will be trained at Houston Methodist and go to another institution. So what we're sharing is the model, not the patient data, gets trained there, goes to another institution and keeps on going and keeps on learning. So we want many other institutions to collaborate. And the other part we want to do is to create a fundamental model for the face, like ChatGPT is a fundamental model for language. This is something called a visual transformer, when we can pre-train a model so we can learn to do many things with very few examples. So we expose this to hundreds of thousands of examples and learns about the face. So the artificial network, it doesn't start from scratch. It already has innate intelligence, so we can adapt it. So I'll stop it here, and we'll take some questions later, and I'll switch it to you, Mark.
Thank you, Dr. Patino. Wow, that's all I can say is wow, that's very, very fascinating. I can't wait to ask you a bunch of questions. And I know there's going to be many for Dr. Brissett as well. So I'm going to turn things over to Dr. Brissett, who's going to speak with us, and then we'll come back and the three of us have some dialogue about all this fascinating work. Dr. Brissett.
Right. Well, thank you very much, Dr. Boom, and good morning to everyone. I'm excited to share with you in relationship to the nuances of ethnic sensitive considerations and facial rejuvenation. This will be a little bit of a departure from the reconstructive aspect that we've just heard about in changing gears to a unique way to think about facial rejuvenation in a ethnic sensitive approach. And so this conversation in relationship to ethnic sensitive considerations is a conversation that's occurring quite a bit around academic settings around the country. And the reason why is that there is a change within our racial and cultural landscape that we're seeing here within the United States. Additionally, there's positive perception and widespread acceptance in relationship to the accessibility of plastic surgery. And as a result, we're seeing a significant increase in plastic surgery procedures for patients from varying ethnic and cultural backgrounds. And from a physician's perspective, it's important to demonstrate cultural competency as it relates to various ethnic groups. And from a patient perspective, it's important that you have an awareness of what's available to you as you may consider these options. And so this is a table that represents the racial demographics throughout the United States, and it was published by the United States Census Bureau. And essentially what this shows is what the prediction will be over the next 25 to 30 years in relationship to demographics in the racial landscape. And what we see over the next 25 years is that Hispanic, African American, and Asian American populations will continue to progressively grow throughout the United States itself. Well, if we dig in just a little deeper in relationship to Houston demographics, we actually see that Houston demographics are a little bit ahead of the curve. And so we live in the most racially diverse city in the country. And what we recognize here when we look at Census Bureau representations is that both the Hispanic American as well as Caucasian population is about 38% and 35% respectively. And then we see Black and Asian at around 17% and 8% as well. And so the question is, why are these demographic statistics significant in relationship to facial rejuvenation and cosmetic surgery in general? And what we're seeing throughout the country is that the shift that we see in the cultural landscape and racial landscape throughout the country is also being demonstrated clinically as well. And when we look at the American Society of Plastic Surgery statistics, in 2017, which is the most current representation and reports from the society, is that 30% of all cosmetic procedures are being performed on non-Caucasian patients. And this represents a 33% increase from 2010. When we look at the distribution from 2010 to 2017, we see that this distribution is seen by 27% increase in patients of Hispanic descent, 52% increase in patients of African descent, and a 51% increase in patients of Asian descent. And so what we see in 2017 alone is that almost 2 million cases in relationship to cosmetic procedures were performed on Hispanic Americans, 1.6 million cases in African Americans, and a little over 1 million cases in Asian Americans. And so the take-home message is that we see a change in the cultural landscape in relationship to racial demographics, and we see a change in relationship to patients that are pursuing cosmetic and facial plastic surgery, and how do we recognize and reconcile that in ensuring that we are delivering care that is sensitive to that subset of patients and people. Now, the two main areas that we see patients pursuing cosmetic procedures are nasal surgery, and then the second is facial rejuvenation. And for the remainder of the discussion, we will focus primarily on facial rejuvenation in general. Now, the concept of facial aging and facial rejuvenation has been here since the beginning of time. It's concepts of beauty, youthfulness have been something that have been pursued for years, and it continues to be pursued now. And now we take, for example, a famous Dutch painter, Rembrandt, who is from the 1600s. He was a famous impressionist, and he is one of the painters that probably had the most self-portraits of any of these impressionist era painters itself. And so he began painting himself in his 20s, and then he died at around 63. But we can see how he is able to reflect the aging process both with intrinsic and extrinsic aspects of aging. You can see changes in relationship to the skin as well as to the bony skeleton and soft tissue envelope as well. And when we think about aging, it's good to be able to have a rubric in terms of how to evaluate the aging process, and then have a rubric in terms of how to treat as well. And so facial aging can be looked at in relationship to extrinsic as well as intrinsic related factors. And the extrinsic factors are sun exposure, smoking, radiation, pollutions, toxins, diet and nutrition, things that you are able to control and protect yourself from, as opposed to the intrinsic factors that relate primarily to internal aspects that one really doesn't have a lot of impact on, but can have awareness. So genetics, diseases and disorders such as endocrine or autoimmune diseases, and these have a tendency to impact skeletal support and often will impact on redistribution of the soft tissue and also skin, muscle, and fat. So this study reflects cross-cultural aging patterns. And essentially what we see is patterns in blacks, Asians, Caucasian, and Hispanics. And then along the bottom, we see kind of age-related aspects as well. And what I'd call your attention to is that when we look at Asian, Hispanic, and Caucasian population, they have a tendency to present age-related changes, at least in this study, at around the same time, about 40 to 50 years of age. But what they do represent are differences in relationship to aging. And so the Asian and Hispanic population will oftentimes present in relationship to more prominent folds and movement in relationship to deep tissue, as opposed to the Caucasian population, which will have more of a global aging-related aspect and more impact in relationship to extrinsic aspects, where we see changes in the soft tissue envelope developing first, and then some changes in relationship to the deeper structures later on. And then we contrast this to patients of African descent, and at least in this study, they presented some 10 years later in relationship to facial aging aspects, and that facial aging was primarily seen and demonstrated in relationship to more prominent folds and some creases primarily in relationship to dynamic movement of the face. And so, if we look at our Caucasian age-related aspects. In the 20s, we begin to see changes, or at least we evaluate the skin, and we really don't see much in relationship to age-related changes. We can look at the soft tissue envelope and realize that the epidermis and the dermis stay relatively thick, the epidermis and dermis stay well hydrated, and we really don't see much in relationship to skin wrinkling and or changes themselves. You fast forward 20 years and you begin to see more dynamic changes in relationship to extrinsic effects. You begin to see thinning of the soft tissue envelope. You see less collagen, elastin. The tissue loses its elasticity and also begins to become more lax and more wrinkled. And this continues to accelerate and continues to progress as the aging process continues. Now we compare this to individuals that may be Hispanic, African American, and or Asian, and what we see is that oftentimes with patients that are more darkly pigmented and that have more sebaceous nature in the skin, have less impact on those extrinsic aspects because of the inherent nature of the pigmentation of the skin. There's about an SPF of 10 to 13 just by having melanin within the skin itself. And so that's an inherent sunscreen or inherent sun advantage in terms of extrinsic impact. But what we also see is that the deep tissue is significantly impacted, and we begin to see movement in relationship to the fat, muscle, and skin that are deep to the structures itself. And so in this individual in the 20s, we really don't see much aging at all. But we move in towards the 40s and we begin to see some movement of fat and prominence in relationship to folds. We can begin to see some descent of the eyebrows and some creases or crinkling within the soft tissue envelope. Fast forward again another 20 years, and again we begin to see some loss of volume in the midface, more prominent in the folds, more creases within the forehead. But one thing that is absent in this aspect is any significant impact in relationship to the skin or soft tissue in relationship to that loss of elasticity and those creases that we oftentimes see when that dermis and epidermis begin to thin. And so we'll just take a look at a couple of patients that I'll present now, and we'll revisit these again in the coming minutes. But these are both patients of mine that have similar life experiences being here in Houston and similar exposure in relationship to extrinsic and intrinsic aspects. And what we can see for this particular patient is you see some puffiness around the eyes. You see some folds in relationship to the cheeks. You see some wrinkling in the skin, and then you also see some muscle movement and banding in the neck. In relationship to this patient, we see forehead wrinkles, we see some loss of volume in the midface, and then we also see some volume loss and prominence in the folds here as well. So when we see these patients, we then begin to identify, well, what are the options in relationship to anti-aging, and how do we best approach this in relationship to different racial or demographic groups? And certainly this concept of approaching extrinsic and intrinsic patterns is important. From the extrinsic aspect, sunscreen is going to be the best anti-aging and preventative treatment that anybody can do, beginning from birth. And so the use of a broad spectrum sunscreen and continuing to reapply is going to be your best option. The use of skincare, cleansers, toners, moisturizers, optimizing diet and nutrition are also going to be great ways to minimize the aging process. And then as we have interventions, lasers and chemical peels are great options that are primarily geared towards more of a Caucasian and European patient, as these lasers have a tendency to potentially hyperpigment for patients that are of more darker or sebaceous nature. And then also chemodenervation in the form of Botox or a variety of other modalities can minimize the effects of muscle activity and creases that we see within the upper and lower face. So in relationship to intrinsic aging, surgical intervention is really the gold standard as it relates to facial rejuvenation. And there's really nothing that can have a more significant impact in relationship to rejuvenation. And this is in the form of facelift procedures, eyelid procedures, or repositioning of fat and muscle. And this can be done across all ethnic subgroups. The concern that most surgeons have in relationship to patients of ethnic descent is that there can be scarring-related issues and the formation of keloids and hypertrophic scars, and so we oftentimes try and stay away from any significant surgical-related aspects. And so that gives us the option to add volume as we see changes in descent and repositioning of fat and muscle, and this can be done, albeit in temporary and/or permanent modalities. And then something new that has been delivered in relationship to and come to the market is the option for minimally invasive techniques and skin tightening procedures in the form of energy that can stimulate the production of collagen, elastin, fibronectin, and all of those other aspects that can tighten the skin in general. And so we'll wrap up here by just going back to these two patients and discussing their customized treatment strategy. So in this particular patient, I approached the extrinsic aspects with skincare, using hydrofacials, microneedling, and Botox, and the intrinsic aspects were addressed with a deep pain facelift, muscle tightening, liposuction in the jaw and neck, as well as hyaluronic acid to the mid-face. And here we see her preoperative photo. In the frontal view, you can see that we have decreased the muscles in the neck. We have softened the creases and crinkles in the mid-face and lower face. From the oblique view, we can see that we've added volume to the mid-face. We've added more definition to the jawline. And from the lateral view, we've been able to refine the jawline and create more refinement into relationship to the neck as well. And then the final patient as a case study is this patient, and we see these patients represented in both Asian, Hispanic American, and Black patients as well. And for her, what we did extrinsically is skin care in relationship to skin brightening and Botox in relationship to her forehead creases as well as her brows. To address her intrinsic aspects, we used a variety of fillers to the mid-face, lower face, and folds. And it's important to say that this patient had no surgery at all. She had office-based treatments that really just addressed her intrinsic and extrinsic aging-related aspects. And so here we see that we're able to add brightness to the skin and tone. We're able to add volume to the mid-face and address her forehead creases as well as her brow position. Additionally, from the lateral view, we can see that we're able to soften her nasolabial folds, add volume to the mid-face, and improve the contour as well. And I would add that these initial photos were in 2016, and these current photos are now 2020, 22. So, we're 6 years later, and she probably looks, 7 to 10 years younger. And so, in summary, what we do see is a change in our cultural landscape. We also recognize that there's an increase in patients of ethnic descent that are seeking cosmetic surgery. It's important to recognize that the aging process differs based on skin types and race and culture. It's important to recognize that anti-aging interventions vary based on this skin type, and there is no one-size-fits-all approach to facial rejuvenation. And approaches to facial rejuvenation should be customized with consideration of race and culture. Thank you.
Thank you, Dr. Brissett. Also fascinating. And before we head on to a little dialogue here, I want to ask you specifically about one thing that was not covered here, and that's your work in Ukraine. Many of you will remember a number of months back, I shared with you a Houston Chronicle article about a team from Houston Methodist, including Dr. Brissett, that went to Ukraine and did much work there. So could you tell us a little bit about that?
Yeah, certainly. Thanks for bringing that up. That has been a project that started as a result of the war in Ukraine, and our Methodist team that was developed here, along with a foundation from Canada, which is my home, called Face the Future. Sent a team in April of last year, and we continue to work to build capacity in that region. The injuries are devastating. The infrastructure is significantly impacted, and as a result, there is a huge need. We did about 112 cases in April. I recently directed a team that went in October. I did not go, but still oversaw the mission. And then we'll be leading another Methodist team that will go back in April of 2024. And so I'll be happy to report back on those outcomes.
Can't wait to hear. So tell us, I mean, just describe some of the injuries you took care of. That's a lot of people affected so positively by your work and expertise you and the team brought to bear on that situation. Pretty amazing. Tell us a little, give us a couple stories.
Well, the majority people that we operated on are soldiers, but we also operate on some civilians as well. And I would say that these injuries are very similar to the injuries that we experienced in World War II. Massive blast injuries where they are losing extremities and also having significant impact in relationship to facial deformities. I think one of the things that surprised me the most in relationship to the extent of injury was the effects of the blast injuries that affected both their vision as well as their hearing. And so we're seeing many men and women with significant facial deformities, like Dr. Coutinho has brought up, but they also have lost their vision. They also have lost their hearing and are really devastated as a result of that. And these are young men and women in their 20s and 30s.
Wow. So you're helping repair lives and many levels. So thank you for doing that with the team. We're proud of you.
Yeah, thanks
proud
for
of the
bringing
team
that
for
up.
doing that. Well, I'm going to start with a couple of questions here. I've been taking some notes. We've had a few come in. I'll make sure we get to those as well. I guess I'll put my primary care hat on, so I'll start with you, Dr. Brissett. So prevention, I'm always thinking about prevention, and my patients are thinking about prevention. If you could talk to every 18-year-old out there and say, how are you going to delay being in your operating room or having all those other things doing there, what are the main messages you would deliver to them? And does that vary across different ethnic backgrounds and colors of skin?
Yeah, absolutely. So I think, as I mentioned, the best anti-aging medicine is going to be sunscreen. And so even before you become 18, we get about 70 to 80% of our sun exposure by the time we're 18 or 19.
So it's really your small kids as they're starting to be out running around.
Exactly, that's right. And so for the mothers and fathers, caregivers and parents is to start by protecting patients early on with UV protective clothing and sunscreens that we're applying and reapplying, and that prevents not just aging-related aspects, but minimizes the likelihood for skin cancers and other aspects that are important as well.
Okay, so number one, above all, regardless. Okay, which we heard, we've done a session here before with some of our dermatology colleagues. First thing they say to everybody is, I'm a terrible patient and I was a horrible kid. We all kind of grew up in the time frame where it was like, people were baby oiling to try and get more sun. So I think we're all paying the price for that now. And then one other question, then I'll kind of go back and forth. But you mentioned in darker skinned individual worry about keloid. Can you talk a little bit about that? Not everybody knows what that is probably.
Sure.
Do we know why? The things we can do to prevent that? I mean, in that case example you showed, you literally had capitalized, no surgery. Was that the reason, or was it more because that was a choice in that situation? So I'd love to hear a little more about that.
Yeah, so keloid is an example of exuberant scarring, and there are a variety of wound healing mechanisms that occur, and in some time along the process, the wound healing aspect becomes derailed and the wound continues to become more vibrant, and it grows outside of the initial trauma
so you get this
of
like
the
lumpy
scar.
growing scar, basically,
Exactly.
in simple terms.
Yep,
right? Okay.
absolutely. And that scar can continue to grow. It's very difficult to respond to medical management or treatment, and it can also become very painful. I see those with patients that may have pimples or ear piercings or surgical scars as well. And they are more common in patients of Hispanic, Asian, and African descent. And they occur commonly in the head and neck area. So
very aesthetic, I mean, or very
absolutely
troublesome for people in terms of appearance.
Yeah, absolutely. Okay. And so we try to minimize placing scars in areas that keloids can develop, and we try to minimize any tension in scars where keloids can develop, because that has the potential for causing keloids as well. And so for patients like the one that I presented, if I can offer a rejuvenating aspect without having surgical intervention, then that would be my preference.
And if somebody has keloid, I mean, it's kind of almost a cat, right? Lots of other lumps and bumps. You're like, okay, we'll cut it off, we'll make it look better. But here you've got something where somebody's responding with all this out of control, essentially scarring, and if you cut them and take it off, you're going to get scarring again. How do you manage that?
Well, it's a great question. I've devoted a significant aspect of my life to wound healing and models of fibrosis. In fact, I've gone into the lab for several years to look at that as well. Here at Methodist, we actually have a keloid clinic where we see patients from all over the city and the country that come in. And we do multimodality treatment, so we can use immunomodulators, we can use steroids to a certain degree. We work with our radiation oncologists to minimize some of the wound healing characteristics, frequent follow-up, and continue to evaluate their quality of life and impact to ensure that we are working towards developing additional modalities and keeping this front of mind.
And last question is it pretty individualized? In other words, okay, I'm an individual and I've had keloid before after I had surgery, or maybe I had an injury as a kid, versus, okay, I've had a couple injuries, I've had surgery, I haven't had keloid. Is there a prediction on people having more problems versus less problems individually, or is it still a risk in anybody with darker skin?
Well, keloids is a risk with anybody as in relationship to trauma. It's more common in patients that have darker skin. It's also more common in patients that have a history of that as well. There are some genetic predispositions as well. And so oftentimes you can make a determination based on what their immunization injection might look like, or if they've had previous surgeries or other aspects. But then the treatment itself is specialized and is catered towards how they may respond.
Got it. Well, thank you. That's very, very interesting, very helpful. I always tell people I learn so much as a primary care physician in these sessions. Okay, so as I think about you, Dr. Catino, I'm always asked these prevention questions. It's hard to say prevent, obviously, and something that you were born with, for instance, but go across the spectrum of the types of patients you see. You showed us, obviously, somebody was born. You talked about somebody in a motorcycle accident, kind of the spectrum of people where you're doing these complex repairs. What are the spectrum of reasons that they're there for you?
So facial deformity can develop in utero because of genetic causes or because intrauterine deformations that can be present at birth. And that is a subset. There are over 500 syndromes that affect the face. Most of them are very rare. But most of the patients develop the deformities throughout their lives. Also, sometimes there's some genetic signal that makes parts of the face grow abnormally. Then we have a whole subset of patients who have tumors. They need tumors that are resected, creating defects, and then all the injuries from trauma. So those are the big groups of patients that have deformities. And also the results, complications from surgeries. Often are other results of defects.
Okay, thank you. That's very helpful. So really outside of avoiding an injury and some of the things we might do to avoid injuries. We can't prevent most of the reasons for seeing you. It strikes me as I look at some of those individuals, you changed their lives because, of course, to be a young individual and with some sort of facial deformity, I'm sure there are so many layers to improvement of their life, improvement of their self-esteem and other things that you see. It must be incredibly rewarding for you to see that.
It is. It happens to me maybe twice a year. It just happened to me a few months ago where I'm in the middle of a busy clinic and a patient came in, and my receptionist, this is a young lady who has a daughter, and she says she was your patient when she was 4 years old. And she was at the medical center. They were by the zoo, and she thought about me and said, I want to stop and say hi to Dr. G. And a doc bit her and volts the whole forehead. And she was the sweetest little girl, and we did all these operations. And she just came and got up without an appointment, without calling. And he said, sure, I'll meet with her, and hugging and pictures and things like that. So it's incredibly rewarding. And that makes my day for a long time.
I'm sure it does. That's really great. So we had a couple questions come across about AI. I mean, obviously, so much what you're talking about is AI, and AI is one of the hot topics that we're all seeing. And of course, in kind of ChatGPT and all the kind of generative AI, we've seen this amazing kind of acceleration and transformation in your field. I mean, some of this predates that by many years here as you look at this. The power of AI seems like it is just moving exponentially. Give me a little crystal ball of where you see this going in your field.
You know, in what I do with, to a degree, medical imaging, AI is incredibly successful. It seems to be perfectly suited for the tasks we're asking it to do because it works very well with crunching numbers, and all these images are basically numbers. I think we're lucky that we don't have the ethical concerns in the kind of things we're doing, so we can move forwards without having that kind of concerns. I think the challenge is either creating mechanisms where we can learn with very few examples, and this is what this pre-training is going to do, or create large networks of people that collaborate so we have more examples for learning. But yes, it's going to be an incredible explosion. And what we're trying to do right now, all this requires background work, but can be implemented on a daily clinical practice. So we're seeing a patient. While we're seeing the patient, can we use these tools in real time to see their deformity, to measure the deformity, to coordinate care? Many of these operations require many surgeons working together, an otolaryngologist, a plastic surgeon, a maxillofacial surgeon, an ophthalmologist. Can we all visualize the final outcome and agree upon ourselves what is the plan to get there? That is something that is difficult to do these days, and I see something that will be worth accomplishing in the future.
So you actually stole one of my questions there. I was going to ask and say, you must collaborate on many complicated cases. Is that one of the advantages of being here at Houston Methodist, I imagine, is you have these colleagues in different fields that are able to help you on very complex situations?
Certainly. We're lucky. Mike Levick in plastic surgery, Anthony and Mas Takashima, all the fellows that are doing all the free flap reconstructions. It takes a team to take care of these patients. Each one of us brings a different specialty within the face, but we regularly work together in this complex cases. None of us can do it alone. It really creates a team, and we're very lucky that not only we have the talent, but we get along incredibly well. We're very good personal friends with each other, and that makes a big difference.
That's fantastic. And some of those cases that you show there, I mean, how long is a case like that? I mean, you obviously inordinate amounts of planning that go into place with all the technology you showed us, and then when you actually are in the operating room doing that, is it one procedure, multiple procedures? When the procedures happen, are these, we're talking hours and hours and hours? Tell me a little more about that.
The ones I showed today, they were single procedures, and that's the advantage of planning, that we can do a single operation when in the past we did multiple. And these are operations that when I first started at Methodist used to take us 12 hours, and now we can do in 4.5 hours, so 5 hours.
And that's a lot of that, I assume, is those templates and things that you're showing.
Yes, correct. Because it saves us an enormous amount of time. I tell my residents, before it was artistic, now it's like putting together a piece of IKEA furniture. It's a lot simpler.
I hope it's less frustrating than putting together a piece of IKEA furniture. Well, that's great. So, well, we had a few other questions come in. One of the questions I'm going to ask both of you, because I can't tell which they were asking or who they were asking, but it's relevant, and that was around, are these procedures covered by insurance? I guess let me go into your realm. Talk about the realm of where things are covered, not covered by insurance in yours, and then I'll come back to you, Dr. Coutinho.
Yeah, for the majority of office-based and even surgical rejuvenation procedures are not typically covered under standard insurance plans. Some patients may have plans that provide that type of coverage, but usually those are out-of-pocket expenses.
Okay, that's what I assumed. I would assume sometimes if yours is in conjunction as part of a major reconstruction or something, that would be covered. But
correct.
Really, for aesthetic reasons, somebody chooses to do that's not covered.
Absolutely.
In your case, I would assume all of these cases are covered, right?
They'll
people
cover
with
by
injuries,
insurance.
people with
we
congenital
have
deformities.
to prove that the patient has a deformity, that the deformity is not mild, it's moderate or severe, and that it is impairing their function. If we can prove that, we prove medical necessity on all those patients that I shall qualify and they're covered by the insurance plans to have surgeries.
Perfect. Thank you very much. And then we had a question come in for you, I think, which was talking about how do we train we do lots of training here. This one, they specifically asked surgeons, but I'd probably even broaden it out to all of our trainees. How do we train them around ethnic sensitivities and around differences and how to customize treatment? Talk a little bit about that.
Yeah, that's a great question. Well, I mean, I think one of the first things I would do is commend you in relationship to recognize the importance of diversity within the workforce. And by being able to celebrate diversity within the workforce, it allows us to have sensitivities in relationship to those that are around us and among us. I think recognizing that cultural competency is as important as being aware of any physical or biological aspects as well is an important aspect also. And so we're seeing that with the discussion of emotional intelligence and other aspects that these sensitivities in relationship to cultural competencies are rising to the top and are becoming as important as any other aspects. And so in relationship to how do we train medical students, residents, and how do we stay current as providers? There are aspects of training, there are modules of training, there are discussions that continue to occur that allow us to recognize the sensitivities in relationship to cultural sensitivity.
Well, and to put a finer point on that a little bit, we do that type of training now across the board because it matters across every person who works in our institution. And I'll say I've had the privilege this year of serving as chair of the Greater Houston Partnership, and so I'm very familiar with all those statistics you were showing, and it's a point of pride as we recruit businesses, companies into Houston, and it's a point of both differentiation as well as strength of our community. And you see, I was looking at your 2050 numbers nationwide, I'm saying, well, we're way, way different than that in Houston, and so we're really paving the way. So the work you're doing, the work Houston Methodist is doing, I think can, like in many things, like the work you're doing, can inform what's happening around the country. So thank you to both of you for everything with that. I think I caught the questions that came in, a variety there. I wish I could ask you all a lot more, but we're running out of time today. So I'm going to move us on to the next step here, but thank you both for being here today. I'm going to give you all just a quick update around some highlights happening at Houston Methodist since our last time together. I always talk about focus on the fundamentals, and either the awards or the metrics will follow. One of the ones we watch out there, it comes from an employer-based group, so it's very important, and it's called Leapfrog. It's a quality metric, really a safety metric, let me be clear, that started probably 10, 20 years ago now, and we're straight A students in Houston Methodist. This twice a year reads left to right. You see we continue to be doing very, very well around patient safety, always coming first in our vision of unparalleled safety, quality service, and innovation. One of the neat awards we got recently, a lot of these just sort of keep happening, was a list of best in state hospitals, and no real surprise. We're glad to see that, though, that we were rated that by Newsweek, as you see here. And literally hot off the press, this came in Wednesday morning. A group with Fortune, but the data side of this is PINC now, it used to be called Truven, looked at what they saw from data perspective, the best health systems in the country. They had 5 large, 5 medium, 5 small. So we were in the top 5 of the large category because that's our size there. And you can see we're in there with Mayo Clinic, Intermountain, which is a great system based in the Utah area and known for their excellent quality and safety. And Vizient, which you've seen many times, always up there with us. Baylor Scott and White here in Texas, kudos to them as well. So very happy to see this. Again, focus on the fundamentals. We'll see these awards. In terms of a couple specific awards, Dr. Eamon Quigley, who you've heard from before and many of you know, who heads up the Underwood Center for Digestive Disorders. We recruited him to Houston Methodist, I don't know, about 11, 12 years ago, something like that. Just won essentially a Lifetime Achievement Award. This is an intermittent award from his professional society. And when I mean intermittent, they don't give this every year. They give this when somebody's really deserving of this for a lifetime of achievement. So very, very proud of Dr. Quigley. I've told the story before, but I remember back, I think it was 2013, the family went on an amazing trip. I highly recommend it, which was a Galapagos Islands trip. And we're sitting there chit-chatting with people on the boat, and it's a couple who were from Dallas. And she had just moved to Dallas from somewhere else, and she was a gastroenterologist. And she said, "Oh, Houston Methodist, you all just recruited Eamon Quigley. Wow, that's huge." I mean, he's that well known, and he's been fantastic for us. Congratulate him if you do see him. We got a nice innovation award locally. Actually, we beat out 2 major oil and gas companies and Microsoft for this in Houston in terms of Corporate of the Year innovation here in the city of Houston. So very happy with that. Of course, here we are talking about our Society for Leading Medicine, and all of you have been so well connected, and this was something helped built when I became CEO, working with Susan. And Susan Coulter, as many of you know, is retiring at the end of this month. I've tried to convince her and talk her out of that, but been unsuccessful. We've celebrated that. And one of the really amazing celebrations she got was she received a Lifetime Achievement Award from the Association of Fundraising Professionals. So Susan, congratulations. And let me just say, on behalf of everybody listening here, thank you for everything you've done in driving our mission forward. We will miss you, but I know you will stay very well connected with us, and I'll make sure of that. I know you'll make sure of that as well. At that same event, Dorothy Abels, who's a wonderful volunteer at Houston Methodist and so many other institutions around our community, I served with her on the board of the United Way, was Outstanding Volunteer Fundraiser of the Year from that same event. So congratulations to Dorothy as well. If you haven't seen this, there's a 3-part series that's been on PBS. These are like 8-minute sessions, so they're really long and fascinating views. We were 80% of the focus of the first, which was talking about some of the innovation work here, virtual nursing and others that are happening to help reverse a national trend of nurses leaving the profession to really amplify their work, make their work better, make their work more meaningful. So we can easily get you the link. It's a great, great show to watch. They did the second one, and we actually were a snippet of that as well. So they brought in some of the great work we're doing in that case around how do we translate for patients from various different language backgrounds, and using a lot of creative and virtual and other techniques, as well as obviously on-site interpreters, which we have as well. We push, as you know, safety and quality. Part of that is reinforcing the culture, reinforcing what our employees and physicians and nurses and others do. So each year we have quality and safety awards. We had over 2,000 of our employees nominating other teams and others for the great work they did, and we had a wonderful event celebrating them as well. Apologize, I went one too far there. Thank you to those of you who showed up for our Rendezvous, a new gala that we celebrated a few weeks back. It was so much fun to do so, and I want to thank the Swansons and the Stevenses for being our chairs of the event. Congratulate our honorees there as well. It was really a tremendous event. 1,800 people attended that, and on a goal of about $5 million, we raised over $11 million. I tell everybody, I hadn't told my wife ahead of time. I'm sitting there, and she turned to me, and I mean, her jaw was like going like this. "No, you didn't do that. You didn't do that." It was amazing, and thank you to so many people here who were so generous around this. And then I'll wrap up with just highlighting our hospital in Baytown. We call it Houston Methodist Baytown now. Houston Methodist Baytown was founded in 1948, actually with a grant from Humble Oil, which of course, as we all know, later Esso, ExxonMobil, to basically help refinery workers there in the area. A few years later, it went into the Methodist Church, and in 1983 became part of then the Methodist hospital system and Houston Methodist. This year they celebrated their 75th birthday. You see some of the timeline there of many of the major achievements. Huge congratulations to them as well. And I want to wrap up by wishing everybody just a wonderful, wonderful holiday season. We're so grateful to you for all your support of Houston Methodist. We're grateful you tune in and listen to these wonderful experts, and I'm so grateful to each of them as well. Have a blessed holiday season and a wonderful 2024, and we'll see you in 2024 if we don't see you first at our event next week at the ION. Thanks so much.